thank you all so much for coming today. We appreciate it very much. I'm Juliana Barnard, and I'm from Accords. I'm a member of Accords. And today is the last talk in the Child Health Outcomes Research Series. So thank you all for coming today. I hope you perhaps caught some of the other presentations. And today I'm going to be talking to you and with you about qualitative data collection and management. I was supposed to introduce myself a bit. So I've been in Accords for about 11 or 12 years now. I have a Master's of Arts in Sociology, so I'm a social scientist that's worked in healthcare and health research. Hi, welcome. For many years. Before here, I was at National Jewish in the environmental and occupational health sciences doing clinical research and occupational exposure research there. So, and I am also an instructor in academics and pediatrics. Come in, make yourself at home. Thank you for coming today. Okay, so the goals for our talk today is I hope you leave understanding a bit more about different sampling strategies for qualitative research. You learn some key aspects of participant recruitment, and we will together explore interviewing and focus group moderation skills that I feel like are really essential and often are taken for granted. It's often assumed that people can interview well and be a good focus group moderator, but there really are some key skills to know for yourself to do it or for your professional research assistant to be able to do it. And also I'd like you to walk away with being better informed about data management for qualitative data because it's a little unique in some ways. Now, last week, Dr. Megan Morris presented, and she did an introduction on qualitative research overall, as well as briefly on mixed methods. So today, I'm going to spend a little bit more time on the these particular aspects, but I hope you can check out her nice talk from last week. It'll be on the Accords website. All of the presentations from this research series will be on the Accords website soonish. I don't know.
Yeah, most of them are up. I don't think Megan's is up yet.
Okay, so soon, in the next week or two, hopefully, you'll be able to, if you were unable to join last week. But if you were not here last week, I'll just spend a little bit of time with orientation to qualitative research. So qualitative research is an approach which studies things in their natural settings, attempting to make sense of or interpret phenomena in terms of the meanings people bring to them. So what does it mean to people? The why does something happen, or why do people feel the way they do, is often explored. And by and large, qualitative research is hypothesis generating. So we're not going to be confirming much of anything, usually. Usually we're identifying new hypotheses. As an example, with qualitative research, you could explore why do some family caregivers experience burden in their caregiving role while others do not. Right? So that is something to understand better, and you could potentially answer that question through qualitative research. We tend to ask questions like, what is the lived experience of blank? So what is the lived experience of being a patient who's been diagnosed with a certain medical condition? Or what is the lived experience of being a medical provider who is a part of the care team for patients with a particular medical condition? What meaning does certain people have? What meaning does something have for people? So what this is all within a health setting, right? So what meaning does receiving a certain type of treatment or having a certain type of option for surgery, let's say, what meaning does that have for people? Or why does something happen or not happen? So what to do, the methods, and with whom your study participants are based on your research question. So that will be key in understanding what to do and how to do it. So that's it for your brief little introduction to qualitative research, okay? So we'll jump into a little bit more specifics about conducting qualitative research. This first is sampling strategies and recruitment. So I wanted us to be more interactive because I'm a qualitative researcher, so I want us to interact. So let's come up with an example that we can use as we go through these topics today and use it as an example throughout. So what is the lived experience of something? What's a suggestion? And I would like us to have something that we could explore from a patient and family perspective, as well as from the medical care team's experience. There's no right or wrong, just an example. What do you think? Somebody, an idea?
Patient with cystic fibrosis.
Patient with cystic fibrosis. So I'm going to show my non-medical training here. Is that applicable for pediatric patients as well as adult?
Mostly pediatrics.
Mostly pediatric. Okay, excellent. All right. Everybody good with that as an example? All right, thank you. All right. Oh, so then if we were going to think about the patient family experience, then we could, in this theoretical example, say, what is the patient's or family experience with having a child who has been recently diagnosed with cystic fibrosis? How about that? And what is it like for a medical care team member to tell a family and the child or adolescent that they have been diagnosed with cystic fibrosis and maybe what the treatment options are? Does that sound good? Okay, that's what we'll do. All right, so then sampling. How do you select your appropriate participants to answer your research question in a qualitative study? You need a sampling plan, just like you do if you're designing a quantitative study. It is key to getting the data that you need to inform your research question. You need a sampling plan from the beginning, from the outset, for the people you're going to recruit to interview or conduct focus groups with, so the people you're getting information and understanding that experience from, as well as your clinic and observation sites. So which hospitals, which clinics, which community-based centers, whatever that is. You have to have a sampling plan for that. And in qualitative research, we do purposeful sampling. And what that means is we purposely choose data that fits the parameters of your research questions, goals, and purposes. This is unique from quantitative sampling. And it makes a whole lot of sense when we're thinking about the lived experience of patients with cystic fibrosis, right? You need to purposely sample individuals that are having that experience, or medical care team members that are part of delivering care to patients that are recently diagnosed with cystic fibrosis, right? Makes a lot of sense when you think about your research question. I want you just to know, this is just an overall quick overview of these topics, but I do want you to know that there are some other sampling strategies that you could consider. These are random sampling, which you're familiar with probably from your quantitative training. However, in qualitative data collection, the way that you can do random sampling is, let's say you get from your medical record a list of all the patients that have been diagnosed with X condition across these time periods. You could randomly sample the list of people that you're going to be recruiting to interview from that list, okay? That's a way you could do it for qualitative. Snowball recruitment. Does anybody know what snowball recruitment is? Please.
It's when you ask people to participate and then ask them to recommend the next round of people to participate, and it keeps going like that.
Exactly. So that is okay. You from the beginning say, I'm going to be doing snowball recruitment. And to be honest, sometimes we get stuck and we have to move to snowball recruitment. If we purposely sample from as we start, we can't find all the right people. We'll go to snowball recruitment. Exactly right. Thank you. So if you do not have a huge list of eligible people that fit within your target population to answer the question of the lived experience of blank, as an example, if you have a few, then you ask them at the end of the interview, can you recommend other people? Do you know of other providers who are involved in this kind of care of these patients with this particular condition? Please.
How do you address the issue of biasness? Because if I refer somebody, I may refer somebody who's a pro in this, who's supportive of what I.
Yeah, so it is something to be aware of. It's a good point. And it is something that you would then need to explore as you're collecting that data to see, is there a whole lot of synergy and overlap in these individuals and how they view this? But a lot of it, to be honest, happens because you all are trained, let's say for a medical provider, right? You all are trained similarly about how do you conduct shared decision making? What is the right approach for treating a patient with cystic fibrosis, right? There's a whole lot of overlap there. One could use the word bias, but it's part of the nature of the structure of the education and training, and so it's a little bit in keeping with that. So it's something to be aware of, and it's true, it exists, but you do want to be aware of it and explore it to try to understand it. Good question. Convenience sampling, this is what we've heard about, and this is, not as good as some of the others, but if you have families in a waiting room waiting to be seen in this particular type of clinic, you could convenience sample those families and ask them and recruit them. And you would just have to say, that was the sampling strategy. Theoretical construct, this is if you're conducting something called grounded theory, which I mentioned just because people maybe have heard of grounded theory, if you've read some articles that have used qualitative research. And theoretical construct is just that as you are developing your theory and you're collecting your data and you're starting to understand how maybe the constructs are related, you purposely sample to expand and understand your theory as it's developing. So that's, we need more time to talk more fully about that, but I just want you to be aware of that. And then finally, the typical, extreme, or critical incident types of sampling. Typical is you're wanting to see and understand an average experience for a particular person or patient. The extreme is more, you've heard more probably about like positive deviance studies, right? Like really understanding the exemplary, the patient who has smoked for 50 years and never developed lung cancer. Well, that's really informative. Let's understand that better. That's an example of an extreme type of sampling if you target those types of individuals. And critical incident are people following critical or kind of major events. A good friend of ours did actually some of that kind of qualitative research around 9/11 and people that were experienced 9/11 and were exposed to all particulates and all these kinds of things. And she did critical incident sampling. Questions or comments about that? So some options you have for sampling within qualitative research. So let's go back to our example of what is the lived experience of cystic fibrosis. So what do you think would be a possible sampling plan for the patients and the families, or the families? So there's purposeful sampling, but is there a clinic here, a cystic fibrosis clinic? There is, okay. So you could start.
You could sample when they get newly diagnosed, what the family's impressions are.
So those that come in to the clinic, getting newly diagnosed, and you would get maybe referrals from the clinic staff to identify the individuals. Is that what you're saying?
Well, actually, they're identified by newborn screening these days.
I'm sorry, they're identified by what?
Newborn screening.
Oh, newborn screening. Oh, okay.
So most of them are diagnosed that way. There are a few that still get missed and don't get diagnosed until a later age.
Mm-hmm. But
usually in the first 6 months, they're all diagnosed.
Okay. So potentially prospectively collecting that data and then sampling them. Okay. What about the medical team members? What would be a sampling strategy for that? What do you think? Do you want just one clinic? It'd be nice maybe to have multiple clinics, wouldn't it? Yeah. So we'll talk more about recruitment here in a minute and how you could possibly do that if you wanted to have multiple sites. Okay. How many is the right number of participants when you are planning your study? So sample size questions. So sample size in qualitative research is ambiguous, which I know seems just so odd and unusual, particularly when you're really trained in quantitative data analysis. But you collect data until you reach saturation of information around your research question. So as you talk to people, humans are super complex. There's always new information you're going to be hearing from people, but you have to get enough information around your research question that you can really feel like you have a sense of, I am now I'm getting the same information over and over as I'm subsequently interviewing families that have been have children who have newly diagnosed with cystic fibrosis, as our example is. Okay? So that's the size that you need to go to, the sample size, is until you reach saturation. For us, quality is much more important than quantity. We never do power calculations. We never do any of that kind of stuff, okay? So and this is how it is by design. So you put it in your methods this way, and that is appropriate, okay? So the quality of the data you're collecting is much more important than the quantity, the number. So you do need a minimum, you need to know a sense of what you have to plan for when you're writing your grant, doing your budget, doing your IRB, right? So in Accords, our rule of thumb is that you need to have at least 2 to 3 focus groups per group. So our example is we have families, parents of cystic fibrosis, and we have medical team members. So those are 2 different groups. So you would need 2 to 3 focus groups, each group with ideally 10 to 12 participants, or 10 to 12 interviews per group. Please.
So how did you get to 10 to 12 participants for focus group? Because I was always trained to do more like 5 to 6 people so that you can actually hear everyone and make sure that you're representing everyone.
That's interesting. So traditionally that has been what the expectation is as a complete group, is that it's 10 to 12 so that you have enough of a variety of ideas and opinions in there. We'll talk more about cascading effect, which is part of the value of focus groups. That's what has been in the literature to be kind of the expectation, but I know in the last several years we've gone to having smaller. I have to tell you, we do that all the time because we can't actually get 10 to 12 people in the same room at the same time, so we will do 5 to 6. If it gets down to like 4, it's getting to be really quite thin. So that is 10 to 12 is the standard though. Other questions or comments? So partly your sample size decision is based on how varied you're anticipating your data to be. So in qualitative research, it might be quite exploratory. There really is not much understood about what, for example, parents of patients with cystic fibrosis feel after they have been told that their child has cystic fibrosis. Maybe a whole lot is already understood. I don't know. But based on that kind of continuum of is it more exploratory versus is it a little more confirmatory, if you will, that's what I'm talking about with varied data. So in the more exploratory side, you should anticipate that you would need to collect more data to get to saturation, because you don't really know what you're going to hear until you sit and talk with these people. Same with the medical team members, okay? I recommend for the IRB is that you put in more and you get approval for more, and then if you end up doing less, it's less of a red flag for the IRB. Okay, so that's sampling strategies, okay, and sample size. So now let's move to recruitment. I'm watching my time just to make sure we're moving along. So how to recruit folks. So this is a very challenging aspect oftentimes. You need to study the lives, viewpoints, experiences, and routines of your target population. So as we're starting to brainstorm and think about multiple sites with cystic fibrosis providers and medical teams, right? How do you negotiate access and at those different sites? Most people are reticent to talk about themselves or their experiences, or they protect access to their group. So that's very common. And so getting in is actually pretty challenging, and it's hard work. So the key is really to have a trusted insider to vouch for your research and express encouragement to participate. So if you have a collaborator, or you should have established a collaborator so that you can have someone who's a part of that institution, ideally to be a co-investigator with you, who can then mention it at their team meeting, send out an email from themselves, or co-sign a letter, because people would want to have a trusted person that they know, because there's so many competing demands, and it's also hard to feel that people often are reticent to talk about themselves and their experiences. And this is true for medical providers too. So this isn't just patients and families. Medical teams are often reticent to talk about what they do and how they do it and why. So it's really important to try to have a trusted insider to help you in that process. Okay? And I would encourage you to think about the different roles that, if you're interested in understanding, let's say from a medical team perspective, provider, nurses, physical therapists, whatever, if you have multiple people and roles that you need to try to understand their experience, then you're going to need that kind of trusted liaison with each type of role, because maybe in some institutions, one provider can kind of get everybody interested, maybe, or maybe not. Maybe you need that nurse advocate or champion to be your colleague and help you as well. Okay. So really begin where you are a colleague or already a member is the easiest, and is why actually kind of drives where we often work with where we have collaborators. So how to gain access. So the approach differs depending on the context with which you want to be recruiting, the participants. So I'll finish this and I'll give an example. Method of data collection, so how you're going to be collecting your data, and the gatekeepers. Those are the people who grant you access, and they may end up being someone different than you initially anticipated. So my good example for this is that we were doing a study of immunizations, HPV immunizations in school-based health centers. So Denver Public Schools has a series of school-based health centers, and they provide immunizations, and this was a few years ago, and when they were starting to roll out delivering HPV vaccination as an option within the schools, and we wanted to understand and recruit parents of adolescents as well as the adolescents themselves about what they thought about their child receiving specifically the HPV vaccine through the school-based health center, that particular setting, versus their pediatrician or their family medicine doctor. So we figured out, how the heck are we going, I mean, you know, DPS, none of us were at the school-based health centers ourselves. We're the researchers. We're on this side. We have a collaborator who's the head of the school-based health centers. He wrote a lovely letter. Awesome sauce. He sent it out to everybody. Well, that's the first step in the process. But we had to actually negotiate access with each school-based health center because there's different levels of management and leadership. So we had to work on establishing rapport and meeting the leaders of each school-based health center. So that worked great. Then we worked out how are we going to access these families. So the school-based health center staff recommended come to registration night and all the families will be there and you can sit near us at the school-based health center table because they have to get consent every year for a child to receive care at the school-based health center. You can recruit parents and adolescents there. Great, we staffed up. There's like a million, you know, DPS, of course. There's a ton of these happening concurrently. So we had like 4 teams out all at the same time. We show up with our letter from the head of the school-based health centers. Well, we didn't anticipate, but we were able to negotiate and work it out. But the principals and the vice principals are running the show in their schools. And so they were like, who are you? No, you don't get to come in here. What's going on? So we had to negotiate access with them to be at the school-based health center table to be able to recruit adolescents and parents for focus groups and interviews. So we were able to work it out. But I just wanted to offer that as an example of the multiple levels and layers that you have to think about with negotiating access, because it's not always as you first anticipate. And you kind of have to really understand the setting and how the dynamics work there and how that operation happens to be able to negotiate. Okay. The method of data collection matters if you're recruiting for interviews or focus groups, right? So it's kind of obvious if you just need a one-on-one versus I need to get 10 to 12 of you in the same room at the same time, right? So that matters with how you're recruiting. You want to collect information appropriately to be able to recruit based on what you're doing. And then I talked about the different gatekeepers. Questions or comments about that? And I highly recommend using a recruitment log. I mean, usually you'll have more than yourself. If you're a PI, you'll have more than yourself doing this work. So you really just need to be tracking all of this outreach, and it really helps you. And it seems obvious, but I have to point out that final column is important, which is when you're reporting to the IRB or to your funder potentially, they want to know how many people you've really recruited and reached out to and how many have, quote, been screen failures, which of course the IRB's documentation is all about drug trials and that kind of stuff, you know, so you have to do that translation. But they want to know how much outreach you've done, who you've talked to, and who's refused. So a recruitment log will often help you with that. Okay. So ask the person that, quote, gatekeeper, the person that is your contact, ask them what is the best method for recruiting with the people you're targeting. With healthcare providers, it's often email, right? With parents, it's often maybe phone calls. You don't have an email address, but you're calling them. So it matters based on what the individuals are who you are recruiting. You have to be okay with no, so that's going to happen. And their early reactions to you are very informative. So if people seem to be off-put or unsure or something, that you should come back to the team and think through that, because that is informative of maybe how you need to modify your approach or who's doing the recruitment, that kind of thing. Okay, so it's valuable information. So just a quick note about recruiting for interviews versus focus groups. Interviews are obviously easier to recruit for and conduct because it's only one-on-one, right? So you're just scheduling a one-on-one interview. And the mode of data collection is a little more flexible in that it's easy to do in person or by phone. Focus groups are harder to recruit for, yet of course there's more data that you're getting in this less time. And all these multiple people to coordinate their schedules is challenging, and that recruitment log is very, very helpful. And it's really important to look for a location that's in close proximity to the individuals that you're recruiting into a focus group. So we have, over the years, used library conference rooms, rec center conference rooms, things like that you can rent. Maybe $20, $25 for the evening, but you want to find something that's not too far for people to travel to if you're recruiting patients, families, community members. If you're conducting data collection with medical folks, you have to go to them and you have to see if maybe ask if you can join and take over part of their monthly meeting, and conduct a focus group because everybody's already there because their schedules, are so crazy, or find a conference space within the hospital or medical setting. Don't use religious locations. That's just really considered to be taboo because there's a lot of influence. So even though a church or synagogue might have a conference room space for you in the community, really don't use that. That's not a great option. We have in the past used the waiting room if we're doing something out in the community, like at a pediatrician's office or family medicine office. After hours, if you can work with the staff on a Saturday morning when no one's there, they can allow you in, and then you use the waiting room space to do a focus group with parents that they already know where the clinic is and they're comfortable with that site. So those are some options. Okay. Another important aspect to think about is language of your participants. So you really want to conduct data collection in the native language of the folks that you're interviewing or conducting focus groups with. So you need a moderator or interviewer who is fluent in that language. So at Accords, we really emphasize this, and of course in Colorado, we have a lot of Spanish speakers. So we hire as much as we can native Spanish speakers because that really matters, that cultural relevance, that understanding. However, for a co-moderator for a focus group, you can have someone who is conversant in the language. That's fine, but really try to have someone who is fluent. It's very important. So back to our cystic fibrosis example. So for recruiting these patients and families, what would be a good way to go about that, do you think?
We just ask a question.
Please.
When you review papers that are sent for publication, what are the common mistakes that people make with regard to recruitment and, if you will, sample selection? And how do you avoid those? I mean, I'm thinking particularly about what happens with parametric approaches as well, but bias samples and that sort of thing.
Yeah, exactly. Looping back to what you're saying. So a single site, right? So we were starting to brainstorm about only having the clinic here be the target population for you to study. Well, that has a lot of what in the literature you would think is a maybe limitation because it's just only one institution and there's a lot of influences that you are unaware of that you can't actually do any kind of confirmation or clarification on if you only have one site. So that's a common mistake, I would say, or something to try to avoid. Single institution. And these are multidisciplinary teams that are the strongest and the most robust in the methods and the design. And so another limitation we see is if people are really just within their own discipline, their own group. They only have perhaps people that are similarly trained that are part of the research team that are helping to inform these decisions about sample size, recruitment strategies, and things like that. So multidisciplinary is helpful. People outside of the particular team. Yeah, things like that. Okay. All right. So for recruiting, I think it would be best to try to have collaborators and institutions outside of your own, as we were just chatting about. And so to have a colleague, you would need to recruit a colleague that's from another institution, or maybe several, and then try to figure out the best recruitment method and understand the institutions that person has affiliation with, what's the appropriate recruitment for those sites. For the patients' families as well as, well, not patients, for example, because you informed me that happens at birth, so the family experience, and then also the medical team members and how they deliver care, right? So my understanding is that differs across institutions, and so different hospitals will make different choices about how they handle that and who's involved, perhaps, in delivering that information. So it's really important to understand what is that local setting and scene to know who you need to recruit to understand that institution and those people's experiences. Make sense? Questions, comments? Okay. So, how to conduct interviews and focus groups. So these are the key skills about collecting this data. So interviews are conversations with a purpose. The organization of an interview needs to match the purpose, and there are a couple different ways that you do that, through structure, type, and then an approach or stance. And we're going to talk in a little bit detail about each of these. And interviews are not just dialogues where the participant gives and the researcher takes. So it's really a shared understanding about what you're asking about that is developed during this interview. So they are co-created. Okay? Good interviews are effective. They efficiently collect the needed information and insights. It advances your understanding on the research topic. So a common problem or common thing that happens is that people get off topic. They start talking about all these other things, and so it might relate to your research question, and it might actually be really valuable information, but it might just be off topic. So you really have to have some of these skills, have a person collecting the data who can help kind of navigate that during the interview live off the top of your head, to keep through and be efficient to collect the data that you're hoping to collect from this particular individual. They should be comfortable. So they generally should feel very comfortable for the person you're interviewing or your focus group participants. And it's the interviewer or focus group moderator's job to make sure that that's how it feels. So it should really be a comfortable experience for them. It takes a lot of work, so there's a lot that the person who's collecting the data is tracking, but they need to really be good at establishing rapport and maintaining the real flow, getting done on time, because people care about being done on time, because that's a sign of respect, right? So you got to be organized. All this stuff has to happen. And securely saved data collection, which we'll talk, or the data, which we'll talk more about today. So it's your job to do it that way, okay? So some things to think about as you're structuring your interview is the organization. It can be structured, semi-structured, or unstructured. So structured is close to an interviewer-administered questionnaire where you or your professional research assistant, you have specific questions and you want them asked in this order and to not deviate. And you have probes added in, like kind of clarification points, and you want those asked. So it's very structured. We tend to do semi-structured because the whole point of talking to this person is you don't actually know all the answers. You don't actually know all the issues and dynamics and things that they think about. So you want it to be semi-structured so that your interviewer can pursue and understand that train of thought. Completely unstructured is more like ethnography and kind of in the anthropology world of kind of just being in the context and observing, not coming in with any specific research questions and or not asking specific questions, but just observing and being a part of it and maybe engaging in conversation. That's unstructured. We've never done that. I've never done that in health services research, but it is a way that you could organize an interview. The type, and these are the most commonly used in health services research, that's what HSR stands for. Informant, you might have heard of key informants. So informants are people that have insider knowledge. So if you want to understand maybe how policies are decided at a high level, you want to interview the head of the hospital as well as the chief financial officer. Those are people with key insider information that you don't know, and there aren't many of them. So that would be appropriate to have and structure a interview as a key informant interview to get that information from them to help inform your research question. A narrative type of interview is where you, it's maybe used with people that are maybe a little bit more marginalized and have more unique experiences that aren't really well understood, that it's an emphasis on allowing the person to just tell their story and not so directed with your research questions. So it's more asking someone, what has it been like to be diagnosed with cancer, and allowing them just to talk about it. That's a narrative style of interviewing. And discursive is something that really gets into the kind of understanding power dynamics and use of language. And so I've seen some interesting publications that look at maybe during palliative care shared decision making and the language that is used by different types of providers. So that's kind of more of a discursive type of interview where you would understand and try to unpack the language usage and how that plays out within what you're studying. Your stance, we're going to talk more about here because this is an important thing. It is your approach and it is your style, and you can do it during the entire interview or you can switch during the interview. And this is something you want, again, your interviewer to be skilled and able to do. So more the traditional orientation to objective research, which is more on that quantitative side, is that interviewers should be kind of in control, create a style of interested but objective listening, don't evaluate, don't befriend, don't teach, don't comfort, don't confront. Because that's more of a traditional type of approach. Well, that is okay. However, interviews within qualitative research are collaborative. They're interactive. You have to co-create and have a shared understanding. The researcher and the participant are on an even plane, and they can ask questions of each other. They're reflexive, and they develop co-created understanding. This is really key to deepen your understanding about the phenomena you're studying. So if you go in as the researcher and you think you really know most of the answers and you really aren't that interested in engaging with this person, interested is probably too strong of a word, but you really kind of think you kind of understand and you're going to be collecting what they experienced from them, that is limiting you in really fully using this opportunity to create a shared understanding of the lived experience. I have an example of a quotation actually from a study I'm on this morning riding the train. I was like, oh, this is a good quote, so I'm going to read it to you and then it'll help kind of elucidate some of this stuff. So technique one, these are different approaches that I was talking about, the stance. So there is deliberate naivete. This one I use a lot. So you as a researcher and your research team, PRA, whomever, will go having a conversation with a family member or a patient and probably will have a fair amount of understanding about the medical condition that you're asking about, let's say. Well, you have to have some deliberate naivete around that so that you can have a shared exchange and you don't come in with kind of, I have a lot of knowledge and you have less kind of approach. You don't want to do that. So on the left side of the continuum is interviewers should always be upfront and truthful about their opinions and motivations for the study. Well, that's a little probably too much where you're showing all your cards. The other end of the continuum is interviewers should be covert and shield their true intentions, feelings, and emotional reactions. That's more that traditional orientation. So this technique is to be in the middle of that, in that you are not sharing everything. You do show honesty, but you remain engaged and really wanting to interact with them, and you kind of are naivete in some naive moment and sometimes. And I'll show you some examples of how to actually do that in practice. Another stance technique is pedagogical, and this is where interviewers should provide advice, education, and insight. It's very valuable when you perhaps have some people that have had some traumatic experiences. So it provides emotional support and it affords the opportunity for the interviewees to reflect on their own experiences. So if there is some provision of sharing of information, because you are representing you are a doctor perhaps, or you are medically trained, or you are representing the research team, it's appropriate to share some of that information and that insight because it's part of that human interaction, and it's also appropriate to help them kind of reflect on their experiences. So these examples like parents of children with special health care needs, they're often quite knowledgeable, but there may be aspects and bits of information that's helpful to share during the interview. And then finally, the final technique that we recommend and is really effective is to be willing to do some counterpointing. So you can't be totally deferential and I'm just going to let you talk unless you're doing a narrative style, right? And then you just let them talk. But if you're doing actually more of a semi-structured type of interview, the interviewer selectively suggests an opposing point of view to stimulate elaboration by the interviewee. So people will contradict themselves at the beginning of the interview. They'll say something, and 20, 30 minutes later, they'll say something that to you seems contradictory or you're not sure how that fits together. You should ask them, and you have to know how to ask them in a respectful way to be able to make sure you understand, because this is your opportunity to walk away with a shared understanding. So ways of phrasing that is, some may say blank. So as an example of, you're interviewing a physical therapist and she says it's very important that children after surgery follow the physical therapy guidelines, and they are XYZ. You could say, well, some may say it's really important actually to allow some flexibility because of the family's preferences. What do you think about that? And then they will elaborate, and then you will have a lot better understanding of their particular viewpoints. Or another way to do that is, I want to ask you more about that since it seems to contradict with blank that you said earlier. So offer that opportunity for reflection. I'm going to be a devil's advocate here for a moment and state the opposing view. I do that one a lot. People get it. That's well understood, devil's advocate. Okay, let's, do that. And then they'll tell you why they don't agree with that particular point or why they do. So that's very valuable. So when you're conducting an interview, you need to be able to use these different stances. So impromptu probing is also important, and this is part of the skill set, that you ask for greater detail, you maybe ask for facts, feelings, deeper meanings, clarifications, and that's not built into your interview guide. It's just something that you kind of have in your bag of tricks when you go to do your interview or moderate your focus group. And here's examples, like if someone says they have diabetes and my scores have been good. Oh, what scores do you have? That's really valuable to know. Meaning-oriented, accurate rephrasing. What I've heard, like for focus groups, what I've heard people say is this and this and this. Did I get that correct? Is that what we've been talking about? And you ask people to agree with you, and you try not to be leading, but that's very helpful. Can you say more about that? Can you give me some examples about what you're saying? Use of silence. Humans hate silence, right? So if you just wait, it's like your kindergarten teacher, somebody will raise their hand and say that. So use silence or people will keep talking. So that's valuable. So, okay, this is where I'm going to read you my quotation because I think this is helpful. I thought this was a good example because the interviewer here, I feel like, did a good job of remaining engaged in the interview and doing this kind of exploring to provide a lot of rich data that this research team is after. So this particular quotation comes from a study where this is a family caregiver being interviewed after their child had surgery. And she's saying to the interviewer, her daughter ended up having a really bad time with it, their surgical recovery. She needed to be constantly moving positions in bed. She wasn't able to do it herself. I didn't really feel like I could get much support from the staff members, the nurses and so forth. And the interviewer says, okay, support in moving her or support like emotional support? What do you mean? Both. Mainly the emotional support because I was pretty much going 24/7. I was really tired. My daughter, and I'm going to paraphrase, she was nice to the nurses, but she would scream at me, is what this mother ends up saying. So it's really stressful for me. And the interviewer says, and she was screaming because she was in constant need for movement because of pain. And the mother says, or mother or father, I'm not sure who, because there was nothing that she could do to get herself to be comfortable. And the interviewer says, oh, she was just so uncomfortable. And she said, yes. And then the interviewer says, okay, and how long did that last? Was it days that she was so uncomfortable? And the family caregiver said, after she was being slowly taken off the pain meds, which was about 2 days, that's when it got really stressful for me because that's when she really came out and started verbally lashing out at me. So the research question was, what's the experience for these family caregivers following surgery for their children? And the questions, the specific question that the interviewer had was, tell me what it was like after your child had the surgery. And that's a huge error, I have to say. It's a limitation of where I've seen a lot of missed opportunities where the interviewer won't engage like this. They'll ask the question, what was it like for your child after she got out of surgery? And the parent will say something like, it was really hard. Oh my gosh, I had a hard time doing it myself. I needed support from the staff members. And then they can move on to the next question. But because of this interviewer's engaging with, tell me more about that. What do you mean? Was it because of she couldn't get a comfortable position? Was it the pain? What was it? So you found out that she was so uncomfortable. And then because of the interviewer continuing to probe, how long did that happen? 2 days. So all that information is really valuable, and you need to remain engaged in that way to help you elucidate that information. Okay? Questions or comments about that? So overall, with interview skills, you really need to be responsive. So researchers have responsibilities for building a reciprocal relationship, honoring their interviewees, and unfailingly respectful behavior. So that's really critical. And remain curious. So I hope you don't mind my silliness, but that dog has a really good sense of the inside of that pipe because its head is in it. So it knows what it looks, feels, smells like, the view from down the pipe. So remain curious. So be engaged in the interview during collection so that you collect all the data you need around your research question. So how am I doing on time? Okay, I gotta move. So phone versus in person. So phone gives you more flexibility. Obviously, it's a little more challenging to establish rapport because most of human communication is nonverbal. So that's hard. And people tend to get interrupted more when they're on phone. So be prepared for that. And you have to work out your recording. Okay, so interviewing skill set. It is a balance between getting lots of detail and information, getting through your material and ending on time. It's really challenging, but you can do it. You need to know key research questions from the outset because people will never go in order. The research team will think it's going to go 1 through 8, and they'll do 1, 6, 2, and then something different entirely. So you've got to be prepared for that. Focus groups are the same. So everything we've just talked about, you organize them and have skills the same way that we've just talked about with interviewing. You do have some additional value from focus groups compared to interviews. I always want to put a plug for focus groups because they really provide a lot of valuable data because of a cascading effect, which is you say something about your experience and then the moderator asks others, what does that make you think of? Are you all similar? Do you feel similarly to what we just heard or differently? And then people will expand, clarify, disagree, all that stuff. That's really, really valuable for you within an hour to hour and a half time period to have that stimulation of thought amongst members of people who are similar in terms of what you need to be getting information around. It can also be very valuable for the participants. Okay, another really nice thing about focus groups I just want to say quickly is that there's also a lot of good vernacular that you get to know. So if you're, this is for, could be medical team members or it could also be with family members or community members. Adolescents, oh my gosh, it's huge with adolescents. How do they describe what you're asking them about? What terms do they use? What words do they use? What don't they use? Build that into your future communication with them, your future guides, your intervention tools. It's very valuable to use that. I'm going to skip that because we don't have a lot of time. So the key thing about focus groups to use that as a particular form of data collection is you want it to match the purpose. So if your research question is benefited from a group effect, so this cascading effect, make sure that that's something that would be your research question would be well explored in that way. You need to think about the extent that participants share that significant experience, and good focus groups strategically combine individuals in that way. You do not want to use a focus group if you want a variety of experiences and there's no commonality to group individuals on. So that's really important. So it would be disjointed and wouldn't work well at all. Also, if it's emotionally difficult, ethically questionable, sometimes it's not appropriate at all. So then you wouldn't want to do it. And power dynamics, medicine, there's a fair amount of hierarchy. So you have to be very thoughtful, and maybe putting MDs and medical assistants in the same group would not work very well because you want people to be honest and they may be a little inhibited. In your handout packet, there is something called a summary sheet or a memoing sheet towards the end, and I wanted to note it. It's just very valuable. We use it consistently. It's required, to be honest, on any teams that I'm a part of leading the data collection. You have everyone fill this out right after they finish an interview or a focus group or an observation, and it's just a really succinct way to gather the initial thoughts relevant to your research questions. And we, in fact, have used it if we needed to help develop abstracts. So the team can pull all those out and look at it together, identify any gaps, identify initial thinking about your data. So it's very, very valuable. All right, quickly, qualitative data management. So qualitative data is considered protected health information by our COMER. That means that you have to think about how qualitative data collection kind of poses some challenges. The data are often collected off-site, right? So you're traveling away from center if you're interviewing in person or conducting a focus group out in the community or at a primary practice or something. The equipment used for the recording, the audio or visual files, needs to be protected in addition to the file. So you have your digital recorder or you have your camera if you're video recording. And so not only do your files need to be protected, but the device that collects the data, records it, needs to be protected. And at the university, the shared folders are backed up every 24 hours. So COMER, I'm not exactly sure at Children's what your policy is, But at Accords, we download everything and then we wait 24 hours because we wait through that backup of the university's shared servers, and then we delete the recording off of the device, the digital recorder or the camera. So then you don't have it remaining. Please.
Do the same rules apply for quality improvement projects as for COMER projects?
Well, you usually have to apply to COMER to see if you are exempt, right?
Not always. Some of mine I apply straight through or internal
Right.
QI thing.
Right.
That says well, they're not testable yet.
I would treat it that way to be on a conservative safe side, but I have to tell you this is specific for kind of IRB approved things that are considered research, and I understand QI projects are a little bit outside of that.
I think protected health information is true whether it's an electronic medical record or whether it's research. If it's PHI, it's PHI. And so the same rules apply to me as a clinician. If I lose my laptop and somehow there's like a Word document on my desktop that isn't like the login, Epic, whatever, like that, I'm liable for that. So whether it's clinical, QI, or research, the same rules apply to PHI.
And it may be operations, like how the delivery care kind of things, so it may not be specifically talking about a patient, but it still is sensitive information, so I would treat it as such. I think this is really helpful. So I really recommend you use a de-identified study number for every person you interview or have in focus group. Use an alphanumeric, like an A21 for someone. The alpha is the group, so it might be the clinic site, it might be the role, the advanced practice providers are all A or whatever. So that helps to identify them, and then each person is sequential. That helps you then with your recording. You would say, I'm interviewing study participant A21. Well, that's de-identified. If anybody outside of the research team hears that, they won't know who that individual is. And then it's on all of your queries. So when you import your data into your software and you run a query, it's labeled A21 is this quotation, so that's de-identified. But then oh, A's are advanced practice providers. I know who's saying this. That's helpful for me. And you keep a crosswalk like you would in other, so keep a secure crosswalk as far as who the people are to their de-identified number. Transcription translation. So here's some resources that we use, some sites. So we pay for transcription and obviously translation. The order is to transcribe it in the language it's spoken and then translate that document. Okay, so that's what the standard is expected within how you do this. Okay, we recommend software because it's helpful to manage your data, and it's really quite required if you're going to publish your qualitative findings. It's pretty much required this day and age that you say that you imported it into a data management system of some kind. Okay. Questions or comments? So I've used up the time. Yeah, pretty much all. So I just want to do a shout out for the qualitative research workshop that Dr. Morris and I, Megan, are teaching. We teach it twice a year. And the next one coming up is February 27th through noon on March 1st. It's intended for Anschutz Medical Campus junior faculty, and we cover all the details of from beginning to end, design to publication of a qualitative study across 2.5 days. It's just an orientation, but it's a lot more than these 2 1-hour deals. And so look for the flyer coming out soon through like academic announcements and stuff if you're interested. And finally, our qualitative methods core, we have some nice resources there, as well as in the end of your packet is a reference list that is very detailed. It's from our workshop, to be honest. So that's something that if you want to do more reading, we would recommend those articles and books. And on our website, you can get more information as well. That's all I have today, folks. Thank you so much for coming. I appreciate it.
Thank you.